He is part of the Autism Treatment Network and now goes by Autism Care Network, the Gastroenterology Committee, and has been on work groups to establish guidelines and recommendations for treatment of GI issues in those with neurodevelopmental disorders. He is a perfect match for Dr. Jimenez Gomez. And like our previous speaker, he works directly with families who have neurodevelopmental disorders in an effort to provide them with the best care possible. He will be talking about dysmotility of the GI system and how it influences behavior. Dr. Williams.
All right, finally found the button there. All right. Thank you very much for giving me an opportunity to speak, and very honored to be talking on the other end of things after our neurologist here. But I'll be talking about the brain gut issues that we deal with every day in our autism GI clinic here at Nationwide Children's in Columbus, Ohio. I have no financial disclosures, but one disclosure I do have, this is definitely a GI talk, so there will be a lot of talk about poop. As we've already talked about, constipation is one of the most common and one of the most troubling that we see in this patient population. The educational objectives, I'm going to go over I'll go over just the most recent data we had. We're starting to put together kind of a database of patients that have been seen in our outpatient GI clinic of what the most common GI disorders are in children with autism spectrum disorders that have been referred to our GI clinic. This is going to be the diagnosis that were actually given by a GI doctor and not just what the complaints and the referrals were, which is a little bit different than what other studies have looked at. We're looking at how the brain-gut interactions seem to predispose the children with autism for GI disorders. This is true not only for kids on the spectrum, though, this is true for kids with all types of neurodevelopmental orders. There is a high association of constipation, not only with kids with Phelan-McDermid that we talked about earlier, and with autism, but also just even ADHD, OCD, oppositional defiant behaviors, all kinds of neurodevelopmental disorders are associated with GI disorders. But what's interesting in this group is not only does the brain gut affect the GI function and development, but it also really affects how we treat or are unable to treat. So looking at our clinic over the last 12 years, our outpatient GI clinic, we pulled the charts just in the last couple of weeks. We started putting this together. This is very dirty data, but it kind of illustrates what we see all the time in various ways I've pulled this data. We got data from over 3,700 patients, and basically 60% of them were constipation, that they were diagnosed with constipation at some point in time by their GI doctor through their visits, whether it be the first visit or the second or third visit. Then you have to, it's 3 to 4 times higher than anything else. Constipation is by far the most common. But what was really interesting looking at this too, when you take a look at this, is all the other symptoms of most of the top 10 are primarily symptom diagnoses, meaning that you make the diagnosis based upon the symptoms. You maybe run tests, do things, but you're not finding necessarily a physiological or organic cause on a test, but you are seeing that there tends to be things based upon symptoms, which really go to the fact that it's primarily a functional or brain-gut interaction that's occurring. So the majority of the symptoms that we see in these kids are due to brain-gut interactions. Now, I'll just focus on the constipation because that's one that we spend our most time on. Plus, it's the one I really see that really causes a lot of revisits and a lot of problems and constipation in the families. The one thing for sure is that, as Dr. Jimenez was talking about earlier, was that there is a lot of interplay between the behavior and the gut, and then the gut feeds back into the behavior. We see a lot of behavioral issues associated with kids who have GI disorders, particularly constipation. They may have a lot more self-harm behaviors, may have a lot more anxiety, a lot more meltdowns and things. But we also see that once we treat those behaviors get better. But sometimes if those behaviors get worse, the constipation, where there's a very much of a bidirectional feed between these conditions that we see. But more importantly, as Dr. Bennett was talking about earlier with his own experience, these children are very expensive. Common things such as constipation leads to a lot more doctor visits, increased ED visits. But not only that, but once they come to the emergency department, if they're having severe pain or fecal impaction, they are more likely than a non-autistic child or a neurotypical child to be admitted to the hospital for these conditions. And then also the chronic condition themselves can lead to physiological changes. It's not uncommon to get kids into the clinic who've had constipation for 5, 10 years. And then when we start doing imaging studies, it's similar to what you're seeing here, which is a single image from a contrast enema, which basically shows the pelvis that is completely filled with stool. But not only that, but the stool ball goes all the way up through the abdomen, up to the diaphragm, practically up to the chest. This is not that uncommon in these situations. And in fact, really one of the first GI papers published on kids with autism was a paper that had in the title Megarectum, that over time, the chronic constipation will lead to a very much of a dilation. And then that in time will lead to non-functioning motility in that segment of the colon, which I'll talk about a little bit more here in a second. So what are the potential causes of the GI disorders? Most of what we see, as I said earlier, appear to be functional, but you do have to also consider, are there organic causes? And there's not really a lot of great studies done out there right now of trying to figure out which ones are organic, which ones primarily are functional, what leads you to think more organic. But we have started looking at, in motility, what kids who present to us with constipation and neurodevelopmental disorders, how many of them actually have a uniformed motility disorder, or do they have basically prolonged functional constipation and at one time maybe just had a normal functioning colon, or do they still have a normal functioning colon? There are evidence out there in animal studies that would lead you to think that there could be pan motility issues, particularly 2 studies. One was a mouse study and a zebra study. The mouse study was from a Pitt-Hopkins mouse model where they had delayed upper gastrointestinal function, where you have a lot of reflux. Like 30% of the patients with Pitt-Hopkins will have reflux, and about 75% will have constipation. The animal study showed that there was definitely a delay in gastric emptying and then delay in the transit in the colon. In Shank-3 mouse, zebrafish mouse model, or I'm sorry, in Shank-3 zebrafish model, they showed that there was a decreased rate of the peristaltic contractions of moving things along. So these genes could be associated with a pan motility disorder, but how does that translate into what we see in our clinic? Recently, we've just submitted a paper with a joint collaboration between us and the Motility Center at Cincinnati Children's Hospital Medical Center, that we combined all our children who'd been evaluated for motility disorder in kids with autism and constipation. And then we used a database that Cincinnati had to come up with a matched cohort. We looked at 35 kids with autism, 35 kids without autism. And what a manometry study is, for those who don't know, is basically you place a catheter into the colon. And that's what this is with all these leads here and these pressure sensors. And what it does is it will measure the pressure changes and actually show you the muscle contractions that are going on within the colon. And here is a representation of that these changes in colors are contractions that are starting proximally and going distally through the colon. Now, a typical person would have a contraction that starts and just have these kind of like repetitive contractions that would start proximally and go distally pretty much to the sigmoid and rectal area. People who have abnormal would have a different pattern and maybe not have any contractions at all. And what we found was when we compared between our autistic group and our control group is that the amount of kids who had completely normal function was the same pretty much in both groups, and those that had abnormal were the same also. So this leads us to believe that there may not necessarily be a different autistic motility pattern, but there definitely are some who will have some abnormalities. But the majority of the kids, when you have a normal functioning colon, means that most likely your constipation is due to functional constipation, which is primarily an issue of actually being able to get the stool out of the rectum. But when we look at our actual autistic kids, breaking it down even further, when we find that, again, 3/4 are normal studies, we have about 17, 18% that the problems with motility is in the distal colon, isolated in the distal colon. And if you remember that image I showed you a while ago, that's what it usually comes from, is that what we think happens is the kids have chronic constipation, that these children, this 18%, had chronic constipation that led to a stretching of the colon over time, and eventually becomes so stretched and so dilated that it can't function well, and it's not able to move the stool through well that section. Now, there was a couple of kids, and this is fairly typical. What we see in our motility centers is that there are a few kids that come, that they'll have complete abnormalities throughout the whole colon that we are able to study. So there are some that do, but the majority is most likely due to functional constipation. And as I was saying a while ago, the functional constipation is more from a lack of being able to get the stool out. Some people like to use the term stool withholding, but it's more than just stool withholding. There's definitely kids who definitely clench and tighten and try to keep the stool in, particularly if they've had large hard stools. It's almost like they develop PTSD. But the other thing we see a lot of in some of the kids that we've tested here is that they have what's called pelvic floor dysnergia. And basically that is, you have a lack of coordination of the muscles. You have to be able to coordinate quite a few muscles to be able to control your bowels and to pass stool out. And what happens is the kids, you need to be able to tighten some muscles and relax others. And what we find is they'll tighten all their muscles at the same time, including the anal sphincter. And it just basically becomes one tight system that's pushing against itself, uncoordinated, and they're not able to get the stools out. The interesting thing is, through the years of working this, I've been doing this now for about 20 years, working with kids on the spectrum, is that the longer you work with it, the more you realize that the neurodevelopmental comorbidities and issues that these kids have tend to be more predisposed to GI problems. The restrictive behaviors, the oppositional behaviors, the obsessive compulsive behaviors, those things, they are highly associated with constipation and with GI issues. You don't even have to have the diagnosis of autism. Even if you just have OCD or oppositional defiant, you're more likely to have constipation. The same with anxiety and sensory issues. There's definitely a lot of sensory issues within these kids. And so it makes it even harder if they start having sensory overload from painful bowel movements or large bowel movements, that they begin to become very anxious. And like I said, they develop like a PTSD. And then the other thing about autism is there's always been a look at serotonin, that it's one of the first biomarkers of autism. About 30% of the people will have increased serotonin. And serotonin is primarily from the gut. And we've known for years that serotonin is highly associated with functional GI disorders. And also too, the sensory processing, again, the connection with the brain is, the reason I show this is that you have lots of sensory pathways, a lot of interaction between your brain and gut. But the thing I really want to impress people is this interaction, the constipation, people like to think of it's just pooping, and what's the big deal? But bowel control is a learned complex behavior. Not only do you have to recognize the sensations coming from the rectal area, which would be like changes in pressure, but those changes go up through the spinal cord. They not only go through the midbrain, but they go to the higher functioning areas of the brain. They go to the somatosensory areas where you sense the things. They go to your prefrontal areas where you actually make decisions on how you want to act upon those. And if you have developmental issues that impair those areas, needless to say, you're going to have problems learning how to poop. The interesting thing about the brain-gut interactions, and particularly with constipation, if you ever worked in a clinic where you're treating kids with constipation, you'll notice a lot of the kids have sensory issues with their mouths and with their eating and feeding refusals. And if you work in a speech clinic or a eating clinic, where kids are coming there with restrictive diets or not eating well, you'll find a lot of those kids have constipation. And there was a study done where they looked at over 4,800 kids, and they studied them at ages 2, 3, 4, and 6. And what they found at the ages 4 and 6, if you go back, that those who develop fussy eating are more likely to develop constipation later, and vice versa. If they develop constipation, they're more likely later to develop fussy eating. Now, there may be a bidirectional component between the two, but the thing that would explain more easily is the fact that the same sensory behavioral issues that lead into problems pooping, lead into problems eating and feeling the texture issues and things in the mouth and then with the swallowing. And so that there is very much a strong connection. Now, why is this important? Well, when we try to treat functional GI disorders, most of the time you're trying to give medications. And one of the telling things in it is that when we look in our GI autism clinic, we find that almost half our kids are not on Miralax. And it's not because we don't like Miralax. It's not because we think Miralax is causing evil things or anything like that. But one of the most common complaints I have from parents is that either one, they can't get their kid to take the Miralax. They can't fool them at all. I've had parents tell me they buy like 6 jugs of Gatorade. They take 1 jug, mix in the Miralax ahead of time, close up the bottle, put it back on the shelf. The kid comes down, they take it off as if it's a new drug. They pour it, kid takes 1 sip, refuses to drink. They go back, get another jug without Miralax, they pour it, guzzles it down. The kid's sensory issues very much play a problem in what we're able to treat. And I think that's also true on the other end of being able to regulate the bowel movements, because if they do take the Miralax, the next most common complaint is we can never seem to go from hard stools to just soft stools. It's either we keep going up on the Miralax and nothing but liquid blowouts is what happens. You give 1 cap, nothing happens. You give a cap and a half, nothing happens. By the time we get 2 caps, they're completely out of control. So a lot of the brain-gut interactions not only causes these conditions, but definitely impairs our ability to treat them. And so just quickly, I'll go over things that it's led to us is that we'll do a lot of biofeedback for our constipation kids, especially for the higher functioning ones. They'll work with our nurse practitioner who's been trained in this. And the other thing we do a lot of is we do a lot of anal Botox injections where we actually put we give Botox right into the anal sphincter. These 2 areas are actually these 2 treatments are actually getting at the issues that we see that are the outcomes of this interaction of brain-gut interactions, where the kids aren't able to sense when they need to go, or they can't adequately control things, or they're so heightened and anxious that they're not able to relax their anal sphincters well. But when these don't work, we'll move on. There have been a couple of kids that are so severe that we've actually had to go to colostomy. Very rare though. And then cecostomies are something that we do a lot of, where you actually put basically a tube into the cecum area. You either make a conduit that's with the appendix, or you can actually put like a feeding tube into the cecum, and you flush the colon every day. The problem with this, it still doesn't get really at the area of the anal sphincter, and the kids can still hold on to it. Plus, they've got to be able to sit on the toilet. Interestingly, the one thing that I find very interesting in the last year that we started doing a lot for our kids who failed medical therapy and are failed biofeedback or anal Botox injections, or are not able to do them, is we place just a simple G tube. And with that, more than one of our parents who've had this in the last year have said it's a game changer for them. We've done about 6 patients. Only one of them have actually pulled it out. Everybody worries about the kids are going to pull it out. And actually, he didn't pull it out. He had a line connected to it. It got wrapped around something. He ran, the line yanked, and the tube came out. They immediately put it back in. He was totally fine. But I think one of the things is not only are we able to give the medications, but we're able to give nutrition if we need to, which is not really much of a problem, but what I think is more important, giving water, keeping these kids hydrated. Because I think a lot of times the chronic hydration or dehydration, plays a lot in the behavioral issues and a lot with the brain-gut interactions. And what we have found that since we've been doing this and treated their constipation, giving them fluids, we've seen significant behavioral improvements in these kids. So again, the interaction back and forth between the gut and the brain and the developmental and the behaviors is that we're able to take care of the gut, it improves the behaviors. And once the behaviors are taken care of, the gut seems to improve too. So just a little brief overview of what we deal with in our clinic. And again, as a summary, the functional constipation is the primary cause of constipation in these kids is what we see. Definitely because of the genetics involved, though, I think we need to be able to, as Dr. Bennett was talking about earlier, we think we need to get to motility doctors fairly quick sometimes with the kids, particularly when they're really failing therapies, because maybe some of these kids, a very small subset due to the genetics, could have a global motility disorder. But the big thing is most of the symptoms we deal with are brain-gut interactions. And not only do they cause the GI disorders, but they really do affect our medical therapies. And not only do we need to think about being able to better detect these conditions in these kids, but I think we also need to think about better ways of actually being able to diagnose them. I've had more than one family come to me, is that all my doctors ever told me to do is just give them Miralax. And as you see, almost half our kids are not on Miralax. We use other medications, we use other therapies, and we have a pretty good success rate with the other ones. So thank you very much.